Welcome to the Experience Better video podcast series. I'm Josh Beekler, PT.
I'm Adam Lease, a physical therapist as well.
And we're good. It's good to be back. Mm-hmm. We're back doing these videos again at a socially distance level.
Yeah.
And we're last week we talked about different shoulder ailments and kind of just some quick ideas on what it could be if it's bothering you. But now we're going to talk a little bit about, we're going to dive into them a little bit more. So let's talk about shoulder impingement.
Okay. So like last week, like Josh said, we talked about a brief overview of what shoulder impingement is. And so now you've been to the doctor or you went to your physical therapist and you're like, hey, this is more than likely what's going on. As a PT, we don't give a medical diagnosis, but we give a treatment diagnosis. And you can say, hey, more than likely impingement, we don't have an MRI in our eyes or anything like that. So it's hard to say with 100% certainty what's going on. But so we assume that you have shoulder impingement. So you're having a lot of pain in the front, overhead, you get to about right here and it's just like, gosh, it just pinches and doesn't go. So during your first initial evaluation with your physical therapist, they're going to look at a lot of things. The first of which just being your posture. They're going to look at you, just say, hey, I want you to just sit normal, and they're just going to look and see where your postural faults are. So like as Josh mentioned in our last video, typically we see like rounded shoulders, kind of that forward head, increased curvature in the middle of the back or in the upper cervical spine, and that's just setting yourself up for failure at that shoulder level because there's not much space there like we talked about last time. It's about a ½ inch of space where there's about 3 major tendons that run. And now if there's any injury to those tendons or if there's any injury to the shoulder, there's just less space. And so now we go from a ½ inch to a ¼ inch. And now as the shoulder mechanics, as that head of the humerus moves up, as you raise your arm up, now it's running into structures or pinching structures as you go through that motion. So we look for those postural faults and then we try to address them. You say, hey, I want you to sit up straight. Now try to raise your arm up. Sometimes it's as simple as that, just changing their mechanics. If not necessarily related to the postural, but if it's something where you can alter, instead of going like a little bit of what we call horizontal adduction or bringing that body across where they automatically bring their shoulder up like this, now maybe it's a little bit in the plane of the shoulder. That allows them to be able to reach up into a cabinet just for functional things. Right. You just alter that movement plane a little bit. It doesn't necessarily fix the problem, but it allows them to do a functional task while we're addressing the problem. Another thing that we would look at is the position of the shoulder blade or the scapula as we call it. So as Josh touched on briefly last time, you can have what's called winging or where your shoulder blades stick out a little bit, and you see this more often in the summer, at a beach or something like that, where people's shoulder blades just stick out. Sometimes that is just their normal anatomy, and if both shoulders do the exact same thing, it's likely not a problem. But if you have one shoulder that's stuck down to the rib cage like it should be and one that's winging, then there's more than likely that's contributing to the cause.
Right.
Another thing that we look for is excessive, what we call upward rotation. So you could have resting posture like this. One of them is already tilted out a little bit, and that's indicating that there's either severe weakness somewhere down here on the muscles that are supposed to hold it in, or there's excessive tightness somewhere on this side or up here where it's rotating out. And so then we would look at cervical spine. Do you have cervical spine range of motion? And because there's a couple muscles in the cervical spine that attach on that top portion of the shoulder blade. Another thing could be like anterior tipping, and so instead of your shoulder blade sitting like this, it's tipped a little bit forward, which is going to bring that acromion down just a little bit on the front side, which is going to put pressure on the tendons.
Sure.
And so a lot of it comes down to posture, and then how do we correct those postural faults? And so if you do have tightness, your shoulder blade sticking out like this, all right, now how do we differentiate? Is that coming from the rotator cuff? Is that coming from the levator scapula?
Right.
Is that coming from teres major? Is it lats? There's a lot of different things, a lot of different muscles insert on that portion. And so then we just go through one by one trying to differentiate. All right, this muscle's tight, we need to stretch. These muscles are weak, we need to strengthen. And then posture, again, comes down to the big portion, is trying to get those shoulders back, especially if someone is sitting at a desk typing all day, or you're doing something where you're writing, like a student, where you're just kind of rounded all day because you're sitting there studying or sitting in class. And so that's probably, I would say 80% of it comes down to is posture and just
Absolutely.
being aware.
And just that muscle imbalance. I mean, it's not very cool to go to the gym and I mean, everybody wants to how much you bench or how much are you doing, how much bicep curls are you doing? You know, those are probably the two worst exercises you can do for this condition. Nobody has anybody ever asked you how much can you row? What's your max rowing capacity?
What bands you use for external rotation?
Exactly. You're up to green now. So it's generally not very cool or very attractive looking exercises that you do to correct this problem. So you see this a lot of times when people newly are working out. Focusing a lot on their bench press, and more of the front anatomical structures, your biceps, your deltoids, your pecs, those kinds of things. The middle and lower back muscles, a lot of times just get ignored. They don't pop like the others do.
Exactly. The mid trap, low trap isn't a popular exercise at the gym.
No, it's not. Because a lot of times you only need a pound or two. A lot of times.
The weight of your arm.
And not a lot of people. That doesn't look very real good at the gym with the pink 1 pound weight. Not a good look. So, but that's something we can definitely coach you through and get you through here.
And typically the shoulder impingement, it's relatively quick. As long as it's not something that my shoulder's been like this for a year and a half.
Right.
Obviously the longer the duration in time goes that you seek treatment, that you're having pain, the more difficult it is to fix, or the more difficult it is to alleviate your symptoms.
Well, you hit a good point earlier about finding a functional way to do the things you need to do, but maybe in a different way, just to open that up a little bit, give you some rest, so we can strengthen what needs to strengthen, stretch what needs to stretch, and then get you back to what you were normally doing. So as long as you're not having to irritate those structures again and again and again, a lot of times it's a pretty quick recovery. Very good. Well, that's all we'll talk about today is in regards to shoulder impingement. Thank you for tuning in, and we'll see you next time.
Thank you.